Okay. So, whenever you want, I can start. May I start?
If you don't mind, we like to periodically interrupt to ask questions. Is that okay?
Yeah, of course.
All right, perfect.
Of course. In fact, I'd like you to participate in this talk. Well, as peripheral nerve surgeons, we connect cables, right? So we fix those cables, but we don't have to just see that part of our work, because there's a CPU, which is the brain. So when we fix cables, we produce changes in the CPA. So those changes are described by certain phenomena which are called brain plasticity. So as peripheral nerve surgeons, we connect cables, but what about the CPU? Please do not forget the brain, and do not forget brain plasticity. This is the main subject of this talk. Please confirm that you hear and see me, see the screen well. Is it okay? Perfect. Okay. So what is brain plasticity, or what is plasticity in general? It is the CNS ability to reorganize and adapt to internal or external changes. So it's a normal process in neural development. For example, when you learn to ride a bike, first you do it voluntarily, but after a while you start to get motor engrams to do it automatically. So this is part of brain plasticity. For whatever you study in neuroplasticity, the younger is the better. So this is me when I was 20, right? And this is me with my family at present. As you can see, there were some external changes in my head, right? You can see it. But besides that, there were some internal changes also. So, and the bad news is that those external changes will go on occurring as I get older. So, if you see this, this graph, you can see that in the red line, the normal brain plasticity influenced by experience decreases as the age increases. And by contrast, in the blue line, you will see how the physiological effort required to enhance neural connections increases with age. So this means that if I want to learn, for example, Russian or Mandarin or a new language, Swedish or whatever, so it will be much difficult for me than for my youngest child, who is Francisco over there in the photo. So brain plasticity decreases over time, and as soon as the age increases. Babies are so plastic that they can even change speech dominance from the left hemisphere, which is normal, to the right hemisphere in right brachial plexus palsy. This was demonstrated more than 10 years ago. So there are some promoters of brain plasticity. The first one is the use. As we say, use it or lose it. The more you use it, the more you preserve, the more you stimulate the brain plasticity or promote the brain plasticity. So if you put a monkey to make, and this is also reported in the literature extensively, if you put a monkey to do always the same movement with the finger, the motor cortex of his finger, the cortical motor cortex, will enlarge, right? The same happens with a blind person who has a very enlarged hand motor sensitive representation in the cortex for reading, for example, being blind. And furthermore, this sensitive cortex invades the occipital lobes, which are devoted to the vision. So in a pain field representation, this is just schematic, you will see how the cortex It's very dynamic. It's a very dynamic process that changes all over the time. So in this case, of course, it changes. And if you just cast a patient for 1 month, you will see also some changes in the motor cortex just with 1 month. This is also described. The maybe second promoter is the physiotherapy. So the directed use. It's not just using, but it's a directed use. And then you also get good results. That's why we have learned that physiotherapy is very important in our procedures, in any reconstructive surgery, especially in peripheral nerves. So the use of, and also internal nerve transfer. So we published this paper about the use of autologous nerve grafts in brachial reconstruction. But anyway, as you will see, this is our protocol for physiotherapy. And we saw that scoring this protocol, the compliance to this protocol in 4 steps, in 4 possible scores, being 1, no rehabilitation, and being 4, a patient with perfect compliance to the rehabilitation, we saw that those patients that had a 4 in rehabilitation also had a 4 in M4. This means they recover much better. So the more physiotherapy they do, the better they recover. And this is also related to brain plasticity. Another article we published in 2015 about the use of training nerve, as you said before, is related to this. So we find that the rehabilitation compliance score, the same one that I talked about a few minutes ago, showed statistical significance regarding the results. So the more you rehabilitate, the better result. Take care. Plasticity is not always positive. For example, if you find a patient with phantom limb pain, this is a type of negative brain plasticity, as you can see. So you can train with a mirror therapy in order to attack this negative brain plasticity phenomenon. I'm going to say just a few words because I don't want to get very deep into this point, but just a few words on how it works. There are 4 mechanisms, and the first one is the most important, is by functional synaptic changes, unmasking dormant synapses. This means there are some connections in the brain that after a good rehabilitation, after physiotherapy, and after using, they are unmasked. So this is how they get better. No, no. So the second one is reducing or modifying protein synthesis in nerve cells. Third, creation new anatomical connections. And this is not very, very easy for an adult brain. Babies can do it very easily, but no adult brains. And the fourth is by elimination of nerve cells, which is apoptosis. But the first one, which is in green, is the most important one. So most of what I'm going to talk about was published in Neurosurgical Focus in 2017. So you can get deeply into this point reading this paper or this one, which is going to appear in a few months in Journal of Neurosurgical Sciences. But the real pioneer in this field is Martin Malesi, who was co-author of the other papers from the Netherlands. So he studied, more than 20 years ago, he studied how the brain changed after a very simple nerve transfer, which is intercostal to musculocutaneous nerve transfer. So I'm going to use the Penfield homunculus, just a schema, in order to introduce you these things. So you will see in the left, in the preoperative state, yes, this is before surgery, a brachial plexus injury patient. Yes, in red, you will see the biceps pathway, which is in red, is section, the trauma affected, the biceps reinnervation. So the cortex is in red, nothing is working. right? And in green, you will see the normal, non-affected intercostal pathway, right? With the cortical motor cortex at the medial part of the hemisphere. And between them, and this is very important, there is a pre-existing connection between those cortex, a black matter pre-existing connection. So we use that connection in the normal life. For example, if you want to lift something very heavy, you don't not only flex your arms and forearms and contract the biceps, but you also contract the intercostal because you want to stabilize, as in this picture, you want to stabilize the thorax wall, right? Then we do the surgery, we do the nerve transfer, we put the intercostal into the biceps, right? So look at this. This is the early phase. In an early phase, what can you expect? You can expect that there are not very deep cortical changes, as you can see there in the hemisphere. And the patient, sorry, I'm going to take out the sound. And the patient, as you can see, I'm not hearing you anymore for a while. I'm going to put it, just make some signs if you want to talk. So as you can see, in an early phase, this is the early phase, the initial reinnervation, the patient needs to breathe in order to get some movement. Yes, no big changes in the hemisphere. But, and this is probably the most important fact, when you see the late phase, you see that the biceps, the previous innervating cortex of the biceps is now in green. So it takes control of the motor cortex. And using that pre-existing connections, it moves the biceps. So that's how the independent movement generates, right? So this is another case, and this is it doesn't matter, it's a phrenic nerve connection, but anyway, the phrenic gets voluntary control without the breathing. So this is the late phase after physiotherapy. And as you can see, those are the plastic changes that I was talking about. And this is brain plasticity after a nerve transfer. And you get voluntary control.
Now, so, I do have a quick question.
My main message, this is my main slide.
Okay.
About the brain changes, but caution. Brain plasticity is limited. The adult brain cannot create a new connection. It just uses a pre-existing one. So donor and acceptor must have some connection between the two motor areas prior to the nerve transfer, which are called horizontal intrinsic connections. So if we use the model of the intercostal to musculocutaneous, the literature says that it has a success of around 60 or 70% of good result, right? So this is it is in green because there is a connection between those cortex and it works. There is a pre-existing connection. The same happens with the phrenic nerve, which leads to very good results, also more than 80% of good results. And the same happens because essentially the cortex organization is the same. What about Oberlin's technique, which yielded a real Copernican revolution in the brachial plexus surgery as a distal transfer? You put some ulnar nerve fascicles into the biceps, you put some median nerve fascicles into the brachialis, or you can change it. So this is the technique, and it gets very nice, good results. And the explanation is easy in terms of brain plasticity. Both zones are very, very close, one to each other. So you get very good results in, for example, in this case of elbow flexion. I promise this is the same patient, pre-op and post-op. It doesn't look like, but it is the same patient. He just cut his hair and put some earrings and all that, and tattoos, but as you can see, it is a very good result in terms of elbow flexion and also shoulder function. Hypoglossal nerve. let's speak about this. I'm going to put on the video. So this is some initial reports of the limited value of the hypoglossal to reinnervate the biceps. So look at this patient. You see, we use the hypoglossal nerve to go into the biceps. We did this surgery more than 20 years ago. So as it says in there, don't try to do this at home. It's not worthwhile. It's not a good surgery. Do not do the same mistakes we did in the past. But anyway, you see that when he moves the tongue, the biceps moves. But the problem is here, it's not the result, only the result, but the problem is brain plasticity. Because you need to move the tongue in order to flex the elbow if you get an M4. And this is the big problem. And the explanation is easy because the connections, the previous pre-existing connections between the tongue and the elbow flexion are not so close, do not exist, so are not possible to be developed after surgery. Again, brain plasticity is limited. This is my main message of this talk. There are alternative techniques for facial reanimation. Basically, you put some of the hypoglossal fibers, instead of putting them into the biceps, which doesn't work, we use it to the facial nerve, as here. So this is basically the technique, hypoglossal part of the hypoglossal to the facial nerve. And this is a wonderful technique. We really like it. And this is a patient, no, I'm sorry, this is the schematic representation of the face and the tongue and how they are so close. And when you move your face, you move the tongue, so everything goes very fluent. And then you get results like this, pre-op on the left and post-op in the right. So you get good symmetry, good eye closure. The patient is fantastic. We are all very happy. Everything is okay. You can see it before surgery. You can see her before surgery and after surgery. Closing the eyes, having symmetry with the mouth, in the mouth. And you can see there is no spontaneous blinking, right? Because the tongue is moving the face. So there is no connection between blink and tongue, right? And what about the emotions? And this is one of the main drawbacks of this technique. We have to be aware. It is a good technique, as I said, but it has some drawbacks. For example, emotions. When you analyze this, you know that the limbic system is managing our emotions. So it is directly connected to the face. So when you feel happy or when you feel fear or wherever, it connects directly from the limbic system directly to the face and you express your feelings, right? But there is no connection, at least for expressing facial emotions, between the tongue and the face. So in this patient, when I say the joke, for example, the spontaneous smile is just in the normal side, not in the reinnervated side, right? So you can expect this drawback in this technique, and you have to say to the patient, okay, you're going to get more than 90% of results regarding facial symmetry and all that, but no spontaneous smile. Again, brain plasticity is limited. And what about contralateral C7? I have to clarify that we don't use contralateral C7, but, well, as you can see, the pathway from one hemisphere to the other is very long. So it's very difficult to get real independence from one side to the other. And this is a very, very extensive review about contralateral C7 use of as donor in brachial plexus surgery. They use patients from all around the world. And as you can see, one of the most important conclusion is most patients could not achieve independent active movement from one side to the other, right? So they had to move the non-affected side, the healthy side, in order to get some movements from the other side. Look at this patient. It's not my patient. It's Dr. Mukund Tate from India patient. He reinnervated this patient when she was a baby, and she obtained very good results. So in this case, you can expect, because babies are so plastic, you can expect good results in terms of independence between one limb and the contralateral limb. So thanks, Mukund, for this nice video. I'm going to show you now another example of brain plasticity and nerve surgery. You have a corneal denervation, right? And you know there is a procedure for corneal reinnervation, which is basically, as you can see, a sensitive nerve transfer, which is in the figure in A, right? A supraorbital or supratrochlear, one of the two nerves, using to be used as donor to go all through the nose to get into the denervated cornea. In this patient, in the figure, the denervated cornea would be, the graft is B, and the denervated cornea is the left eye in the figure. You can see it in the right. Okay, so this is basically we are harvesting on the right. We are harvesting the graft, and in the other side, you will see how the procedure is done. You go through the nose from one side to the other, and this is basically the surgery. It's a very easy and rewarding surgery. Greg Borchell from Toronto Sick Children really specialized in this and popularized this surgery. He's a good friend, and it is a sight-saving surgery because you get sensation in the cornea. So it's wonderful because the patient avoids to get a corneal transplant, or even having a transplant. They get good results in terms of corneal reinnervation. So here we are using the donor side, which is the supraorbital, in order to make the nerve suture, and now we are splicing the nerve graft, which is the sural nerve graft, into 4 parts, and then we put the grafts, the 4 parts of the graft, in each quadrant of the eye, right? This part of the procedure, of course, is not done by neurosurgeons, it's done by ophthalmologic surgeons, our colleagues. So you can see they reach almost the cornea, and then they go into the cornea and reinnervate the cornea, exactly. So this is a wonderful solution for this problem. And again, they are closing the sclera, and okay, it's wonderful. So we study this with confocal microscopy to see how the reinnervation really occurs, and it really does. And we present this paper about confocal microscopy and the real reinnervation it produces. But I ask you to see this video. This patient had a reinnervation of the cornea in the right eye. Yes? Can you see the graft over there? The grafts, the nerve grafts? Okay, so the donor side was on the left supraorbital nerve, and the receptor was on the right side, on the right eye. Okay, so the ophthalmological surgeon, my colleague, leave a stitch over there, and he took it some months after the surgery. So the reinnervation was already done, right? So the patient the patient is now saying, well, I'm okay, I'm very happy, I feel the cornea. When I put some drops, I feel them, but when the surgeon took out the stitch from the cornea, from the reinnervated cornea, guess where did she felt the pain? Over there, right? Because that was the donor nerve. There is still plastic inability to feel the cornea normally, okay? So it is protective, okay? She felt the cornea, but still feeling it on the other side. And the same goes, for example, when you want to reinnervate very subtle movements like intrinsic movements of the hand. So in this interesting article by Neil Simon from Australia, a cortical plasticity may be more extensive for gross motor than for fine motor movements. And I saw that you were showing some cases of this before my talk about supinator to anterior interosseal and anterior interosseal to brachialis. So you get good results in terms of reinnervation. Yes, I do agree, absolutely. But, and she can do some grasping, and she uses her hand. She had a lower trunk palsy after a tumor resection. The result is good, but you cannot ask this patient to play the piano because she won't be able to do the fine movements because the movements are just very simple. And this is also explained by plasticity because when the hand is reinnervated, you create a very big black hole in the cortex, in the sensitive and in the motor cortex, right? Which are the biggest part, devoted for the hand and especially for the thumb. So I'm going to conclude now my talk, and I want you to play a game. I'm opening the sound, okay, it works. So, you know, I'm coming from Argentina, and we love soccer, and our national hero is Lionel Messi. But let's play this game, okay? It's not that game, it's not football, it's not soccer, it's another game. Let's imagine that you are at your office, there's a lot of patients outside waiting for your exam, and there are many post-op patients, and suddenly the lights turn off and there's a shortcut, and you ask your secretary to bring some candles, not to have a romantic dinner, but to see anything. Okay, but the problem is that you don't have computer and you don't know what type of nerve transfer you perform, right? So let's try to guess what was the nerve transfer we performed, which was the donor, which was the receptor, and all that. Sorry. So look at this patient, 16 months after the surgery. We reinnervate the elbow flexion. She's starting to flex the elbow. He still didn't reach the normal reinnervation, the normal result after this technique. But anyway, can you imagine which was the donor nerve?
Flexiona el codo. Ajá. Espera. Dale, flexiona el codo.
Oh, I'm going to take out the sound. Well, as you will see.
Can you hear us?
Chat. Anyway,
can you hear?
Go on. Those are the problems of being outside not in the auditory. So just by Zoom, but you can see that he's moving the trapezium muscle, right? So he had what? He had a spinal accessory to musculocutaneous nerve transfer, right? So this is the initial result. He needs to trim the shoulder, to contract the trapezium, to fire the spinal accessory in order to get some elbow flexion. So when you are in this situation, you have to train a lot in order to get some brain plasticity and get some independence of movement. 2 years after the surgery, this is another patient. And again, he's shrinking the shoulders, and you see some spontaneous flexion of the elbow. So there is some limitation. Anyway, he can flex the elbow without doing without moving the shoulder. So he's in a maybe more advanced stage of the rehabilitation, 2 years after the surgery. And of course, the nerve transfer we perform is spinal to musculocutaneous. What about this patient? Take a look. Again, elbow flexion was the target. He's doing just 14 months after the surgery. Very good result. But as you can see, when I ask him to inspire, he's inspirating, he moves faster and he reaches a bigger angle of flexion. And now he's just breathing, and you see how spontaneously there is a movement of flexion, right? So again, brain plasticity, as I said, is limited. There is not always a good independence. Of course, framing to musculocutaneous was the nerve transfers we performed. This was studied in this article we present in JNS, Journal of Neurosurgery, a couple of years ago, and we studied how the framing to musculocutaneous nerve transfer was evolutioning after the nerve transfer. And we saw that there is a strength difference when the patient inspirates. That means when he fires the phrenic nerve, there is a near 10% of difference. So they get 10%, around 10% more of strength when they fire and inspirate the phrenic nerve in terms of elbow flexion after phrenic to biceps, even many years after the surgery. So we call that the Popeye effect. And this patient was operated more than 10 years ago, phrenic to musculocutaneous. And as you can see, without breathing, she gets a very good elbow flexion. It is a very nice M4, everything is okay. But when I ask her to breathe, to inspire, as you can see, she's inspired now, and there is some subtle, very subtle movement of the biceps. So still, in a young patient, she was operated at 16 years old, still you can see some movement of the biceps. But in the real life, when you ask the same patient to lift one box, okay, she can do it, no problem at all. But when you ask to lift 3 boxes, for example, well, she needs more strength, so she inspires and she gets a 10% extra strength in order to accomplish the task, right? So they use the inspiration normally in order to get more strength. And you know what? The most interesting thing is that we do the same. We do the same. When you have to lift something very heavy, you make a big inspiration in order to stabilize the thoracic wall. So it is a natural movement. Let's see this patient. Let's go on with this game. I'm playing the game alone, I'm sorry, because I have no feedback.
Anyway, Mariano, can you hear us? Are you able to hear us?
The donor, I'm going to tell you, the donor is the phrenic nerve. I'm going to ask you, which was the receptor? Phrenic nerve, donor. Receptor, it was directed for elbow flexion. Do not see the shoulder. Shoulder was spinal to accessory, spinal accessory to suprascapular. But you see elbow flexion with inspiration. But when he inspires, can you see that he also moves the pectoral muscle? Is it clear? Inspiration, moving the pectoral muscle. So the question would be, which was the target? If you want to reinnervate at the same time the pectoral and the elbow flexion, you're going to use the anterior division of the upper trunk. And this was the resector. Okay? So this is the surgery. We are cutting now the anterior division of the upper trunk. And we are putting some phrenic nerve, the complete phrenic nerve directly to the anterior division. So you can expect that if you do this surgery, you will get not only reinnervation of the elbow flexion, but also some contraction of the pectoralis. Now we prefer not to do this surgery, and we use a longer graft directly to the lateral cord, or maybe to the musculocutaneous, but a longer graft in order to reduce misrouting of the nerves, of the phrenic nerve fibers. So we published this year this article about the nerve graft length and the percentage of recovery. So the nerve graft length is not a problem. We'll use long graft, even 15 or 18 long grafts in order to reinnervate, and we got comparable results. But when you use shorter graft or no graft at all, as I showed you in the video, you will get some misrouting of the growing axons. Another case, 5 months after the surgery, and you can see he's waving the hand, and there is some movement of the biceps. This is a normal, and you all know that, this is a normal situation after an Oberlin procedure. This is the initial reinnervation after an Oberlin procedure. We prefer, as Jorge Clifton does, to use the median nerve to the biceps and to use the ulnar nerve to the brachialis. We change the original Oberlin's procedure according to an advice given by Jorge Clifton, my friend, our common friend. So I'm going to probably finish with this patient. C5, C6 injury, was operated 13 years ago. Now it is completely recovered, as you can see here in the post-op, long time recover, very good reinnervation of the shoulder, of the elbow. Everything is okay. We are very happy. We are having a party. He's playing with a basketball. So everything is okay. Anyway, the question is, as it says in the lower part, what did we use to reinnervate the axillary nerve? What would you use? You would all use Somsack procedure, right? Probably. You will use some triceps fiber going to the anterior division of the axillary nerve. But in this case, we use a different donor. Can you tell me which donor did we use?
Pectoralis?
Exactly. We use the phrenic nerve to the axillary. Were we crazy at that time? Yes, absolutely yes. Do not do this at home. This is not a good procedure. But anyway, I want to show this in order to show how brain plasticity works. Anyway, the patient is perfect and there's no big deal about this, but I think at this point we have better strategies. Anyway, as I said, do not try to do this at home, but
are you able to hear me?
That you will get good results. But more importantly, in terms of brain plasticity, it's better to use also, in terms of brain plasticity, it is better to use the Somsack procedure. So this is our hospital. Now I'm exactly here at the Hospital de Clínicas in Buenos Aires. I hope you can come here in the future after this nightmare will end up. And this is our team, constituted by orthopedic surgeons like Gustavo, a physiotherapist like Danilo, and 2 other neurosurgeons, Sheila and Gonzalo. And this is a normal working day. In the past, not now, but we used to make big rounds and see all together the patients, including our ultrasound colleagues and some trainings and all that. So again, the final phrase, caution, brain plasticity is limited. The brain cannot create a new connection. It just uses a pre-existing one. And finally, this is my family, and I want to thank you all for your attention.
Mariano, can you hear me?
Yes.